Welcome everyone to our case conference today. We're doing another cold case. Super excited for this case today. I actually have no idea what's about to happen. Manny, one of our current third-year residents and future chiefs, has prepared a case for us, which I'm sure will be excellent. Our discussants today, we've got two second-year residents, Hoda and Leela, and then we've got Jason, one of our third-year residents and future chiefs as well, will be helping us discuss. Again, all of our discussants are blinded to the case. It's going to be completely new to them, and we're going to watch them work through this case in real time. It's going to be a lot of fun. So, Manny, go ahead and get us started.
All right. Can you hear me?
Yep.
All right. So you are the MICU resident and are called by the ED to admit a 71-year-old female with a history of NASH cirrhosis. She presented to the ER with reported black stools and diffuse weakness. Labs are pending, but borderline hemodynamics is the reason for admission to the ICU. So you head down to see the patient. Patient tells you that over the past 48 hours, she's had 2 to 3 episodes of black stools. Her bowel movements have been loose, which is normal for her, but the color change did concern her and her daughter. She has no prior history of GI bleeds, denies any hematochezia, reports no hematemesis, but states that she's noted some frank blood in her mouth today. She has no significant abdominal pain, except for very mild tenderness located to the epigastrium with no radiation. She also mentions to you that her urine is darker appearing than normal, possibly blood-tinged. She states that she was recently discharged from a rehab facility and has been struggling to function independently at home. Denies any syncopal episodes, but has been dizzy when rising from a seated position. She has no chest pain, shortness of breath, blurry vision, subjective fevers or chills. Her legs feel very heavy.
Excellent. That is a jam-packed first piece of information. So I'll throw this one to our discussants. Guys, take it away. What are you thinking right now?
All right, I'll take the first shot. So this 71-year-old lady with NASH cirrhosis presenting with black stools. So number one thing that I want to confirm is whether or not that's actually melanoma, because I've had a lot of occasions that patients report black stools, but that's not actually melanoma. However, with her other symptoms, this lightheadedness, concern for maybe also existing hematuria, looks like, and history of cirrhosis. She might have actual blood in her, like blood loss in her GI tract. Because it sounds like it's a slow process, not causing like hematochezia or hematemesis. I'm not at this point concerned about like esophageal varices, but I do want to know more about her cirrhosis history, whether or not she's had good follow-up, whether or not she has like actual gastrointestinal manifestations like Petechiae. Again, not super concerned about esophageal varices, but I do want to know if she's been screened for those. And then I want to know about her other medications and other pre-existing conditions that would put her at a higher bleeding risk.
Hoda, that was absolutely fantastic. That was a really, really excellent summary of kind of that initial thought process. Leela and Jason, what are you guys thinking?
Hoda, can you do you remember? I can share what are some of the scenarios where people have reported dark stools and then it hasn't actually been melanoma? What has been happening in those situations?
I mean, sometimes it's just dark colored. And then when we say, okay, is it tarry black? And then they say no. Or is it sticky and black? And they say, no, it's not sticky. So I guess it depends on some dietary changes. I guess it's like if the stool stays in there for a long time, it may get a little bit darker. But I've had several occasions. And then sometimes I get more history, sometimes I have to do a rectal, and then it turns out not to be a melanoma.
Yeah, some other things that I think about as far as substances. So iron, oral iron can cause dark stools. And then a common one that people use is Pepto-Bismol. So heartburn, nausea, indigestion, upset stomach, dark stools is another thing to think about. The thing that I'll comment on is the dark urine. So kind of a brief, quick and dirty differential for that. Certainly someone can simply be dehydrated, and their urine can be very concentrated, common things being common. Moving into the slightly less common, if someone has some kind of element of rhabdomyolysis for some reason, and they have myoglobinuria, that can cause dark urine. And then more specific to the liver, bleeding, etc., we think about sometimes high bilirubin in the urine causing dark urine. But I just want to remind everyone something we all know. Not all bilirubin goes to the urine. So if this is bilirubin causing dark urine, it's going to be as a result of a conjugated bilirubinemia rather than an unconjugated bilirubinemia.
Jason, that was great. That was awesome. I love that teaching point about thinking about dark urine. It's something, a lot of patients tell us, and I think actually diving into that differential, dehydration, the myoglobinuria, bilirubinuria, really, really excellent. I think real quick, because I think Hoda and Jason both got at some really good points, and I just want to make sure that we're all on the same page here. I'm just going to go to the whiteboard real quick, and we'll outline a high yield point that Hoda brought up. So one of the things that Hoda mentioned was how do we think about melena, or how do we think about kind of big GI bleeding causes? And one of the things we always talk about is output color. And this is how I think about it. So this seems really basic, but when you're bleeding, your output color in the GI tract is either going to be black or dark, or it's going to be red, right? So it's going to be light or it's going to be dark. Typically, when you've got the red blood coming out, it means that it's moving faster, it's closer to the exit, so it's coming from the mouth or very near to the rectum or the anus, or it's going to be a higher volume. And so I know we all have our differential for that, gastroesophageal varices and arterial bleed, but those are the things that I'm thinking. And then for black blood or black stool output, like Hoda mentioned, you're thinking about melena, so things that need a longer transit time, where the blood can be broken down in the GI tract. And typically it's going to be a smaller volume because it needs to sort of sit there and it needs time to be broken down by the GI bacteria and the bowel. And so I think Hoda, Jason, you guys did a fantastic job of talking through that, talking about myoglobinuria, dark urine. I think that's a great place to start. Do you guys have any other questions for Manny before we get the next piece of information? All right. So
Sorry, Danny, you cut out there. Am I up?
yeah, sorry, Manny. Sorry about that. Go ahead and give us that next piece of information.
All right. So we'll dive into some past medical history since you guys are having some questions about that. So patient has a history of breast cancer. She's status post mastectomy and treatment with no known recurrence. She has a history of NASH cirrhosis, for which she had been following hepatology at an outside hospital. Kind of given her age and her functional status, she had actually been deemed not to be a transplant candidate. She also has a history of hypothyroidism, a history of a recent COVID-19 infection about 2 months prior. 2 weeks after her COVID-19 infection, she was hospitalized with hepatic encephalopathy and she was found to have MSSA aortic valve endocarditis. With septic emboli to the brain, she was treated with IV antibiotics and discharged to a SNP to complete her course. During that hospitalization, she also developed AFib, and she has a long-standing history of depression as well. Do you guys want to chat about that a little, or should I keep going?
Yeah, I think let's give our discussants some time to talk about that. That is, again, a lot of information, but some really, really good stuff in there. So to our discussants, Leela, Hoda, and Jason, what do you guys make of that past medical history, and how might it change the way you're thinking about, or not change how you're thinking about that HPI?
Do we know what complications of cirrhosis she's had in the past?
Sorry, Leela, one more time.
Do you know what complications of cirrhosis she's had in the past?
Yeah, so she's been hospitalized a couple of times with hepatic encephalopathy, but to her knowledge, she states that she's never had a significant GI bleed causing hospitalization.
So then again, as I said before, so this AFib, I'm assuming she's on some type of anticoagulation for that. So then again, that increases my concern for GI bleed and like risk of progression to more serious and potential life-threatening GI bleed, given her age and other comorbidities. Yeah, a lot of other past medical history, this COVID-19 and all, I'm not sure if I want to make something out of it. But at this point, that's the big thing I've had. And then, yeah, Manny, do you know if she's ever had any scopes, any screening for esophageal varices or any diagnoses of any type of GI complications of cirrhosis? Because I'm guessing if she's had like hepatic encephalopathy, she has been decompensated or is decompensated. So any other manifestations of that?
Yeah, so when you were heading down to the ED, you didn't have that information, but while you're talking to the patient, you were able to find some records. And you see that her last EGD was 4 years ago. She had portal hypertensive gastropathy, but no evidence of esophageal varices at that time.
So I think right now I just wanted to go back a little bit to the abdominal pain that she's having, because I actually recently learned a really cool schema to approach, ruling out the emergent abdomen. And there's basically 4 categories of things you want to think about when someone has abdominal pain to rule out sooner rather than later. So 1, you want to look for someone who has the surgical abdomen. So someone who has a surgical emergency, acute appendicitis, severe cholecystitis, some kind of obstruction. So that's the surgical abdomen. 2, you want to think about the vascular abdomen. So that's someone who has acute mesenteric ischemia or other kind of vascular pathology going to the gut, because that is also an emergency. 3rd, you think about the cardiac abdomen. So someone who has like epigastric pain that is actually an inferior MI manifesting with those symptoms. And then 4th is the gynecological abdomen. So someone with ectopic pregnancy, ovarian torsion, or also like septic PID. And thinking about those things first. So tying it back to this specific patient, she has some recent risk factors for both hypercoagulability with some of her recent like infections. And then she also has a history of endocarditis where she was embolizing stuff from that. And then she had a bout of AFib, which also puts her at risk for embolic disease. So specifically, something that's making its way into my differential diagnosis, in addition to the other things, is acute vascular abdomen.
Jason, that's a great schema for thinking about abdominal pain. I actually had not heard that before, but I really like the way you broke that down into kind of 4 big causes. That's excellent. Leela and Hoda, do you guys have any other thoughts about the abdominal pain or about the past medical history?
No, I just wanted to say that's actually, as you said, a great schema. Go ahead, Leela.
And I think one of the additional questions I had for Manny, just hearing that story, and one thing I think we always sometimes forget about asking is to tell us a little bit more about her valvular issue. Sounds like she got treated for her bacteremia, but do we know from that hospital stay how large the vegetation was, whether there was like a concomitant valvular abnormality associated with it? Did she get a surgical valve replacement or something like that? I think that's always something, like Jason said, to kind of tease out to make sure we're keeping that in focus.
Yeah, so when her endocarditis was diagnosed, I don't have the size with me, but it didn't cause any profound sequelae at that time. She didn't have any cause for a valve replacement or anything along those lines. She had a pretty uncomplicated course, actually, tolerated the antibiotics pretty well, and from a cardiac standpoint, was deemed to be pretty stable early on.
Perfect. that's a super succinct clarification. That's awesome. So basically just got antibiotics, no sequela, treated her, and then went on her way. Perfect. Do you guys have any other questions about the past medical history or HPI before we get some more data for this person?
Just wanted to add one thing in there. Another thing with the cardiac abdomen to consider is abdominal aortic aneurysm. That's another thing that kind of falls into that category.
Great. So
Just another quick question I had, was was she hospitalized with COVID, or did she just have it in the community?
Yeah, she was just diagnosed with it, but did pretty well from a respiratory standpoint and was never actually hospitalized.
that's a great question, Leela. And why did you, how would your thought process change if you found out that she was hospitalized with COVID as opposed to community acquired and community treated?
I know that COVID's kind of like obviously in flux as a disease, but I know there's been some question of hypercoagulability associated with it, just in the setting of like severe sepsis or like a hyperinflammatory response. So knowing how sick she was with it, I thought would be helpful.
Yeah, completely agree. I think that all the risk factors that come with being hospitalized, and especially with COVID, is she hypercoagulable now compared to what she was a couple months ago? All right, I think I'm on the same page as you guys. I think we still need a little bit more data for this person. So I'm going to turn it back over to Manny to give us the next piece of information.
All right. So a little bit about social history. She recently returned home after her stint at SNF. She lives with her daughter. She has pretty limited functional status, and family has to help her quite a bit. She's a former smoker, quit about 20 years prior. No current alcohol use, no drug use. She has non-contributory family history. She's allergic to aspirin because of reported itching, and HCTZ is listed as an allergy due to hypokalemia. Her current medications are lactulose, rifaximin, fluoxetine, Lasix, Spiro, amiodarone, and she is not on any blood thinner or antiplatelet agent. While she's giving you her medication list, while you're reviewing that with her, she begins to cry and states that she has not been very adherent to all her medications.
All right, so all of this just at this point shouts to me to hypercoagulability. All the like recent past medical history, the fact that she's allergic to aspirin, so not taking that, I'm assuming, and then not on any type of anticoagulation, AFib, recent COVID, all of that. At this point, I'm more like leaning towards like an embolic event.
That's great, Hoda. I think that's really, really excellent reasoning. And I like how you sort of put your nickel down that she's perhaps got an embolic event. She's maybe hypercoagulable. It's a way to tie together some of those symptoms. I think that's a great start. What do our other discussants think about the history, social, past medical so far?
Sorry, is that you, Leela?
I just wanted to add also the fact that it looks like she's not very mobile and active, and other risk factors.
Agreed. The only thing I was just going to say quickly is she's saying that she's not adherent with her medication. So just one by one, going through that short list, what would that look like if each of those medications were taken away? So lactulose and rifaximin, obviously the big thing you think about is portosystemic encephalopathy manifesting. Fluoxetine, taking that away abruptly, you may have some withdrawal symptoms. I don't know exactly what that looks like, if I'm going to be honest with you. I don't think it causes acute GI bleeds. Taking away her spironolactone and Lasix, other than, messing with her electrolytes a little bit, you are concerned about volume overload. But then the deficiency of amiodarone, when it's used as kind of a rhythm control, rate control for her AFib, it may have predisposed her to more frequent episodes of AFib. So that's the one that's standing out to me, that if she hasn't been taking as much as she's supposed to, may be a problem, with the understanding that amiodarone literally lasts forever. So if she's missing a dose here and there, probably not a big deal. But if she's missing many doses, it could be problematic.
Really like that. Really like that summary of the medications, Jason. I think that's a really important point to remember about amiodarone is that half-life is almost a year. And so really need to dive in with whether she's been taking it at all, but I think that's a great point. All right. So I think right now, before we get some vitals and before we get an exam, Hoda's already talked about the possibility that this is an embolic event, but Peter mentioned in the chat that we still, I think, and correct me if I'm wrong, guys, I think we still have a pretty broad differential here. And so what I want to do right now is let's just stop and let's put our heads together and let's create a top 4 differential diagnosis that we can kind of center our reasoning around as we start to get some vitals and some exam and some lab findings. So group, what do you guys think is going to be our number one thing right now?
I think number 1 and close number 2, like if we want to think about an embolic event like mesenteric ischemia, something like that. And then number 2 for me would be still with her hypercoagulable state, even like despite that, given her past medical history of PAG would be like GI bleed. Potentially from that, PAG gave is also another manifestation of portal hypertension in patients with cirrhosis.
And Hoda, for the interns and the medical students that may be on the call, can you tell us a little bit more about GAVE?
Yeah, so it's gastric antral vascular ectasia. So basically, there are just little arteries, if I'm not mistaken, that get a little bit like engorged and can bleed.
Great. Yeah, that's exactly it. And so the typical boards question for this will be that they scope the person and they've got what you call like a watermelon stomach, and you've got these engorged vessels which basically run vertically in the stomach, which basically makes it look like a watermelon, essentially, sort of the rind of the watermelon. And GAVE is a not infrequent cause of bleeding in cirrhotic patients, and something that I don't think we think about as often. So I really like that. And then anything else we want to add to this differential, or do we feel comfortable kind of moving forward with this list?
I feel comfortable moving forward with this list, but we definitely have to rule out a variceal bleed, even with her lack of varices in the past. Slightly less likely because of the, how stable she is, but it's a can't miss one.
Yeah, absolutely. And I think especially with that red blood in the mouth that Manny told us about early on, something we absolutely can't miss. And I think that's something we're all thinking, but just to make sure we've got that on the list. And then, I think right now, rightfully so, we're all thinking about possible bleeding, manifestations of cirrhosis, but just to make sure we don't forget about that dark urine, anything you guys like to have on here to sort of keep our differential broad still, or are we going to tie the dark urine to these other events?
It's a broad differential. Anything that could make the direct bili go up, anything that could predispose to rhabdomyolysis, anything that could make her dehydrated. But I think getting a basic set of labs would, kind of direct us one way or the other as far as thinking about the dark urine. So I'm going to spare everyone of listing off infinite possibilities.
Yeah. I think that's great. I think that's a really good point to make, is that, as internal medicine doctors, it's not our job to guess the differential from the door, guess the differential from the HPI. We use the HPI, we use the past history, the social history to guide our next workup. And so with that in mind, I think this person's absolutely going to get a CBC and a BMP and maybe some LFTs, of course, with their history. But are there any other labs or any other, things in that nature that you guys would want to get prior to imaging? Obviously, we're going to get an exam, but any other labs that you might get now that you wouldn't get for another patient?
I want to check a lactate. I don't know if you mentioned that. And then coax.
Yeah, I think that's great.
Yeah.
Yep, I love that. So lactate and coags, right? We don't know her vitals yet, but if this person's tachycardic or hypotensive at all, that lactate will be helpful. And then coags, I think, right, we're all talking about bleeding. And so a really, really good thing to remember to order. All right, but I like you guys, I'm interested to see what this person actually looks like and to get some actual objective data here. So I'm gonna turn it back over to Manny for the next piece of information.
All right, you guys are doing fantastic. I wish I could have you with me on my 28-hour calls. So we'll start with the vital signs here. Patient is afebrile, the temperature 98.3, heart rate of 109, blood pressure of 98/59, satting while on room air. On exam, she's ill-appearing and diffusely weak, but she's alert and oriented ×4. On HG&T exam, you note dried blood crusting on her outer lips, swollen erythematous gums with evidence of fresh blood pooling in her mouth. There's no palpable cervical lymphadenopathy. On her skin exam, you note a scattered petechiae along the anterior chest that is beginning to coalesce. There's also petechiae along her upper extremities. She has 2 peripheral IVs at this point, but there's no evidence of oozing blood. She has lower extremity swelling that is 2+ pitting to her thighs. Her cardiac exam is notable for a 3-out-of-6 systolic murmur, best heard in the left lower sternal border. Lung exam is normal. Abdomen is notable for distension with a positive fluid wave and mild tenderness to palpation along the epigastrium, but no rebound, no guarding, no pain out of proportion. Her rectal exam shows mixed brown and black stool. On neuro exam, she has no asterixis. Her cranial nerves are grossly intact. She has normal strength and sensation throughout. She has no dysmetra or nystagmus.
Manny, let's stop there for a second. That is a absolutely phenomenal exam. And I think I got excited when I heard a couple things in there. So what I'm going to do is I'm going to turn it back over to our discussants. Guys, what do you think about these vitals and this physical exam?
It's classic for post-COVID. I just want to say this is a classic post-COVID syndrome. Go ahead, Hoda.
Yeah, not slightly, tachycardic. And then blood pressures are soft. I don't know how big of a person she is. Sometimes that's like the baseline. I do want to check orthostatics because sometimes like a normal-ish blood pressure can fool us, for lack of a better word. So those are the big things, the 2 big things that stand out to me from vitals.
Perfect. So before we go on, I think the thing, Hoda, you're calling out there is, and I know some people are probably sick of hearing me say this at the U, but there's something called the shock index. And this has been pretty well validated in emergency medicine and trauma. But essentially what the shock index is it's your heart rate over your systolic blood pressure. And if you have a shock index and you put these numbers in, anything greater than 0.9 is associated with bleeding and transfusions. And essentially, the way I use this is when I'm triaging someone, especially at Denver Health from the ER, if their heart rate is higher than their systolic blood pressure, that cues me in that maybe there's a kind of a underlying systemic process. They're losing blood. Perhaps they're a little bit higher risk than one of our average patients coming in a bit more stable. And so I think this is something that I started using a lot as a 2nd and 3rd year when I get that initial call from the ER. And now I think more interestingly, what do you guys think about this physical exam?
I'll throw in a couple of quick comments. So sometimes when there's a lot going on, but I start hearing like buzzwords, I start to associate them with other diseases and then figuring out what's going on there and tying it back to my patient. What do I mean by that? So she has swollen gums with evidence that they've recently been bleeding. And when I think back to med school, I think of, people with hemophilia. So people with like a problem with their coagulation cascade. So something is wrong. If that is true also with this patient, something is wrong with her, coagulation cascade. And then I hear that she has petechial rash pretty diffusely. And a lot of times when we hear, people having a petechial rash, we more associate that with disorders of the platelets. So that also suggests that this lady, if she's, following the textbook, has something wrong with her platelets as well. And so, I'm thinking of diagnoses that may involve both platelet dysfunction and coagulation problems. The low hanging fruit is something like DIC. However, when you make a diagnosis of DIC, that then portends to the next question, well, why do they have DIC, which has a fairly broad differential.
Jason, that's great. And so as you were talking about this, I was kind of filling in this chart. And I heard this schema from Gurpreet Dhaliwal, who's one of the often on the clinical problem solvers, and I think it's actually fantastic. And so his way of thinking about petechiae, he says petechiae is equal to bleeding, which is what Jason mentioned. And so when you've got petechiae and you've got bleeding, the ways you can break it down, like Jason said, are platelet dysfunction. So you either have thrombocytopenia, low platelets, or a functional problem. You can have a problem with your coagulation cascade, so a hemophilia, an underlying coagulation abnormality. And the very last thing is you can have a vascular problem. And so what he means by vascular problems is, you can have a vasculitis, so you can have an itis or a capillaritis. You can have a structural problem, for instance, like a collagen vascular disorder, or something like scurvy, where you've got, you've just got a collagen problem and you're bleeding because of that. Or you can be throwing out emboli from a central source, classically, endocarditis or something else. And these emboli are lodging in your vessels and causing the vessel to break down. And I think actually you guys have all been talking sort of around these things, but this is I think how I'm going to start thinking about petechiae from now on. What other thoughts do our discussants have on that based on that exam?
What about that murmur?
Yeah, what do you guys think about that murmur?
She recently had endocarditis, right? So I wonder if she has any lingering complications of that. Something else that I wanted to add was with cirrhosis, I often need to remind myself that they are both at a risk, depending on what stage they're in. Usually in the earlier stages, they're at a high risk of clotting versus bleeding, but they both lose protein CNS as well as their clotting factors. So actually, that lady still admitted that she had GI bleed, and at the same time she had DVT and B. So something that, again, I need to remind myself often. So with this, findings like petechiae and bleeding gums and all that.
Hoda, I think that's a fantastic reminder. I think so often we think about cirrhotic patients bleeding, but they are just as hypercoagulable in some cases, just for the reasons you mentioned: decreased protein CNS, but factor VIII, which is not produced in the liver, remains there, and so they are hyper and hypo. And then the other point that I wanted to bring up before I think Mandy gives us a little bit more information is, she's got active blood in her mouth, correct? And I think when we think about GI bleeding in melena itself can be caused by any time blood gets in the GI tract and gets broken down. So if you've got fresh blood in the mouth from a nosebleed or from bleeding gums, that can lead to melena if you swallow enough of it. And so I think you guys have done a fantastic job so far of keeping that differential really wide open, but sort of narrowing appropriately. Any other thoughts and comments from our discussants before Mandy gives us a little bit more information and some labs?
This would be remarkable, but just like a quick pearl. So she has blood in her nose, she has blood in her mouth, and she's having melenic stools. So something to keep in mind, not necessarily in this patient with a petechial rash and bleeding gums, but when we think about nosebleeds, so an anterior nosebleed coming from the nasal septum is, you pinch it off and it's no big deal. But a posterior nosebleed, and I'm forgetting, I think it's like the inferior sphenopalatine artery. It's an arterial bleed. So a posterior nosebleed, it can be an arterial bleed, and people can exsanguinate from such a bleed. So, and it's a emergent indication to go to the ER or to the OR with ENT. So just something to keep in mind, like in this lady without other comorbidities, without rash, without bleeding gums, without a murmur, something that would be in the differential for her.
Perfect. Yeah. I think like always keeping our differentials broad and recognizing that melena may not necessarily mean a classic GI bleed. All right. I am very, very interested in what these labs are going to show us. I think you guys are. So with that, I'm going to turn it back over to Manny.
All right. I will give you first her EKG and chest X-ray. Her EKG showed an irregular rhythm with a rate of 115. There were no ischemic changes. In comparison to her prior EKG, there was no change except for the change in rhythm. Her chest X-ray interestingly showed diffuse GGOs and a focal nodule lateral to the left cardiac apex. And just a reminder, she was satting well on room air at the time of that X-ray. So getting into labs now that you guys are pretty excited to get here, her CBC had a white count of 6.1, a hemoglobin of 8.3 from a baseline of 10, and a platelet count of 1. The CBC was repeated, and we asked PATH to review, and they confirmed those initial lab values. Her metabolic panel was notable for a bicarbonate of 14, a BUN of 53, a creatinine of 1.9 from a baseline of 0.9. There was no anion gap. Her LFTs were notable for a total bili of 4.2 and an albumin of 2.5. Other values were normal. Her lactate was normal. Her INR was 1.4. PTT was 38.4, which is very mildly elevated. Upper limit of normal is 36 to 37. Her haptoglobin was 7, which is low. Her LDH was 362, which is high. Her fibrinogen was 132. Her D-dimer was 2.7 with an upper limit of normal of 0.5. UA showed 1+ blood with 2 to 5 RBCs. And I can stop there. I've got a couple more labs if you guys are curious about anything else.
Yeah, let's stop there. All right, guys. A lot to process. What do you guys think about these labs?
That's a low haptoglobin, right? Sorry if I missed that.
Yes.
Have we fractionated out her if they're Billy?
Yeah, it's predominantly direct. Like 3.8.
And then very last question I had, I think you guys might ask this too. Do we know a prior baseline creatinine and a prior baseline platelet count?
Yep. Prior baseline creatinine is 0.9, and her prior baseline platelet count is about between 60 and 80.
I think you need at least 2 platelets to start to form a clot, if I remember correctly.
That's probably correct, Jason. Okay, so any other questions you guys have about this, the CBC or the BNP? And I think we're going to stop there, and we're going to have either Hoda or Leela give us their one-liner before we get some more, perhaps some more labs.
I can give it a shot. So this is a 74-year-old lady with a history of NASH cirrhosis who is presenting with melena with an exam and labs concerning for bleeding mediated potentially by like a hemolytic anemia syndrome. And given her heart murmur and AFib with RVR, concerning for an embolic event possibly causing her bleeding. Sorry, that wasn't the most elegant.
No, Leela, you're not giving yourself enough credit. That was fantastic. And I what I really liked that you said there was the hemolytic anemia, right? Because you heard low platelets, you heard a lower than normal hemoglobin, you heard an elevated LDH, an elevated D-dimer. Given that you're concerned for hemolytic anemia, is there anything else, any other information that you'd want from Manny, or anything else that you'd like to see based from these labs?
Could we get a smear? Is there a smear?
There is a smear, and I can share that with you. So her peripheral smear showed rare schistocytes and almost no platelets visualized. We actually spoke to the pathology department and asked them to look at it again because I couldn't quite believe that her platelet count was what it was. But they confirmed that they could see almost no platelets on the smear.
Excellent. All right. So Leela gave an awesome one-liner. Manny's filled us in on some lab data. I want to go ahead back and revisit our differential, and let's think of the top 3 things we think this could be before we get a little bit more information. And then just so I know for timing, Manny, how much information is left before we get a final diagnosis? How many pieces of information?
Yeah, one more, maybe a few sentences, and then that'll be it.
Perfect. So let's start right here, and let's give our differential as of right now with all the information we've got. So what's our number 1?
Based on everything, mine would be like a TTP HUS type syndrome. Thrombocytopenia, elevated creatinine, hemolytic anemia.
Great. And Hoda, what between...
And I would like to check a retic too.
Okay, perfect. So you would like to check a retic as well. Between the TTP and HUS, which one would you be more concerned about right now?
I mean, HUS is the one that has renal failure into it, right? And also a component of encephalopathy. HUS would be, for me, the one that I'm more concerned about.
Great. Yeah, so HUS typically more associated with renal problems, TTP more associated with neuro issues. Awesome. Just to make sure we're still thinking a little bit more broadly, what would we have as, perhaps 2 and 3 on this differential?
Couple of quick things I'm thinking about. So cirrhotics are susceptible to all infections more so than the general population. So sepsis of unclear etiology leading to DIC is one. And then another thing that I'm thinking about specific to this lady, if she has decompensated cirrhosis and then she's developing a hemolytic anemia in the setting of decompensated cirrhosis, and one thing I'd be want to rule on her is a portal vein thrombosis leading to decompensated cirrhosis, leading to like a hemolytic anemia.
Great. And a throwback to Peter Heisen, who helped us out last week. There's also an entity in cirrhosis called a spur cell hemolytic anemia. And essentially what that is an end-stage manifestation of cirrhosis in which the patient gets a hemolytic anemia or some sort of hemolytic anemia associated with that. So just to call back to one of our prior sessions. I think that list is excellent. Anything else you guys want to add or any other imaging or studies you'd ask for? I will say the one other point that I would add here, and I think this is somewhat esoteric, but are you guys familiar with the entity called Hades syndrome? So essentially what Hades syndrome is a combination of aortic stenosis and an acquired von Willebrand factor deficiency. And so with aortic valve damage, as a patient, as the blood crosses, the von Willebrand factor gets chewed up. And so the question I would wonder and ask is, in this patient who just had some aortic pathology a couple weeks ago, is there something going on with her coagulation cascade or something with sort of the parts of it, which is leading then to something like this? Like, is there a way that we can tie her aortic valve and her endocarditis into the hemolytic anemia, right? Because I think we always need to try to tell a story about our patients, and that would perhaps be one way to tie this whole thing together. Any other thoughts from our group? Any labs you'd want to send? Do we need to send the Adams TS13 or anything like that in this person? I will take your silence as a definite maybe. All right. So I think right now what I want to do is I want to go through each of our discussants, and I want you guys to put your nickel down and tell me what you think is going on here. And then we'll finish with that last piece of information. So Jason, why don't you go first?
Man, I am torn between 2 and 3, but I'll say 3. I'm gonna stick with she has a big portal vein thrombosis and entered that cascade that I previously mentioned.
Excellent. And I think, one of the things that might point to that, she's got some worsened edema, but may also not be compliant with her medicines. But I really like that thought process. Leela, what are you thinking?
I think I'd say maybe she's like quietly septic and we're not realizing she's DIC. But
Great. I think that's awesome. Right. Remembering that our liver patients can hide any number of infections, and always getting blood cultures from these people. And if this blood culture comes back and shows us gram-negative rods or something else, then absolutely. I think that's perfect. And Hoda, I think I know which one you're going to say, but what are you thinking?
I mean, Jason, you're a brilliant person, but the only reason I'm not going with 3 is that with any type of vascular issues in the liver, I would expect LFTs to be like super high. Generally, like vascular issues are like the ones that we see LFTs like ALT, AST over 500. So yeah, Danny, you guessed it. I'm going with 1, and then yeah.
Awesome. Yeah, and actually, I'm going to. I'll put my nickel down as well. I am going to agree with Hoda on this one. I think we are going to see a hemolytic anemia, which has affected the kidneys, and I'm going to be interested to see what perhaps triggered any of this. So, with all that being said, I'm going to throw it back to Manny to take us home here.
That was an awesome discussion, you guys, really. A lot of the similar thoughts that I had in my mind, kind of the scary things. But I'll kind of share with you the course here and kind of how things played out. Just a few labs to round things out. I got a DAT on her, and that was normal. Checked an ultrasound that showed liver cirrhosis, but the portal vein was patent. Blood cultures did not show any evidence of any growth. So the patient was started on ceftriaxone, a PPI and octreotide, given concern for possible variceal bleed, those kind of lower on the differential. I went ahead and gave her a dose of platelets. 20 minutes after, or 30 minutes after that dose of platelets, her repeat CBC showed a platelet count of 2. And so the next series of information will give the diagnosis.
Awesome. So with that little piece of information, what did that guy, does that, Jason, obviously we don't have a portal vein thrombus, so unfortunately we've ruled that one out. But what are you guys thinking now?
I think with her platelet count not coming up, it speaks more to like a consumptive process of some sort. So like one of the first 2 choices.
Completely agree. Hoda, what are you thinking?
I'm still putting my nickel down on 1. I think, yeah, the fact that it didn't go up means that like if it's a destructive process, basically, it's just no matter how much platelets we're giving her, she's just destroying them.
The other thing I'll throw in there, and this is a little bit of a limitation of my knowledge. So the other thing to think about is like an immune thrombocytopenia, but I'm not sure if a direct like Coombs test would, I mean, I associate that more with like an autoimmune hemolytic anemia rather than a immune thrombocytopenia. But that's another thing to think about. If you give them platelets and then the platelets don't go up, that they're being eaten by the immune system.
Yeah, and I think, Jason, correct me if I'm wrong, I think the DAT being negative would make that a little bit less likely, but agreed. I think that's a really, really good thought. Yeah, I'll be honest with you guys. I'm still leaning towards the TTP-HUS spectrum. I think the fibrinogen being above 100 points me a little bit away towards DIC. But I think ITP is a really, really good thought. So there's something in this lady's blood, there's something in her body, which is breaking down platelets faster than we can give them to her. And I think we will figure out what that is here in just a second. So Manny, what was the final diagnosis and how did you come to that conclusion?
All right. So credit where credit is due. I had a nice lengthy educational conversation with our HEMONC fellow. And a few things that he pointed out to me were very limited what processes will cause such a profound thrombocytopenia with other cell lines being pretty preserved, such as her case. And her lack of response, like Leela said, kind of was in line with a consumptive process. The reason I think that we leaned away towards TTP or HUS was, again, how low the platelets were and how everything else was kind of within normal-ish. She didn't have a fever. Her anemia was a little bit worse, but kind of close to baseline. Renal function, I think we initially attributed that more to being hypovolemic, being hypotensive, and her neurostatus was kind of within normal. So the diagnosis was ITP superimposed on decompensated cirrhosis. That was a fantastic discussion from you guys because this remains a diagnosis of exclusion. And so you guys did such a fantastic job of thinking about every other reason that this patient could present this way. So I really applaud you for that.
Manny, that is a fantastic case. I will be honest, I have never seen ITP in a cirrhotic patient. And so that is something I am definitely going to add to my differential now. Manny, you did a fantastic job taking care of this person. What were some of your big teaching points from this case?
Yeah, so just a few things before the teaching points, just so you guys know kind of how the patient ended up doing. The patient was started on IVIG and dexamethasone, and within 48 hours did have a slight increase in her platelets up to 7. But unfortunately, the patient developed inuric renal failure, and a TTE actually revealed severe mitral valve disease. You guys remember her chest x-ray? She had mitral valve perforation and evidence of mitral valve vegetation, though her blood cultures were negative. Likely, this was a sequelae of her initial presentation with endocarditis. But just a quick few teaching points. ITP affects about 2.5 people per 100,000 in the U.S. The mechanism underlying the development of ITP is production of autoantibodies against platelet antigens, specifically glycoprotein 3b2A. Secondary causes of ITP, things like HIV, hepatitis C, it's theorized that viral antigens are similar enough to platelet antigens, and through something called molecular mimicry, you can get inappropriate attack from antibodies onto your own platelets. And what's really cool about this case that the Hem-Onc fellow shared with me is dating back to April, there have been several case reports temporally associating ITP after the diagnosis of COVID-19. ITP remains a diagnosis of exclusion, but treatment centers around steroids and IVIG. Platelet count will rise within 24 to 48 hours. Second-line treatment includes rituximab, thrombopoietin receptor agonist, and splenectomy in refractory cases. And the last thing I want to share with you guys, the Hem-Onc fellow shared with me in an acute situation, if this patient was bleeding and her hemodynamics were worsening, we should give her platelets. Even if we don't see an improvement in the platelet count, it will help stabilize the bleed. Thanks again.
Manny, that's fantastic. That is a absolutely wonderful case with a great summary at the very end there. Thank you so much to to Manny for preparing a fantastic case. And thank you so much to our discussants. Any final thoughts on this case?
No, that was fabulous. Thank you, Manny, for sharing that case with us.
That was truly epic, Manny. The few hairs left on top of my head are like standing straight up. I'm exhilarated.
I was just curious if she ever ended up getting scoped. I guess like someone with a platelet count of 1 could bleed with
so GI was consulted, but because of the platelet count, it was kind of too high risk, and they had low suspicion for variceal bleed, kind of given how she was doing. And since she elected to go towards comfort care, it wasn't pursued.
Really great job, guys. Thank you so much to our presenter. Thank you so much for our discussants. I had a blast. That was a wonderful case. Everyone, have a good day. And like we said in a prior email, if you guys are interested in doing this, hopefully these guys can vouch. It's a lot of fun. And getting the diagnosis correct is only part of it. Sort of the path to get there is just as fulfilling and just as fun to work through. So thanks a lot, guys. Have a great day.